The Duncan's classification basically is a fracture in a already existing THR. But what if the bone breaks when you do THR, like intra-op fractures? And we will have a lecture on that also. And they have classified even those like intra-op classification, the metaphyseal, diaphyseal, and a beyond stem fracture. These are the fractures which happen when you are doing surgery, and everybody gets them. I have my own share of fractures. I have bones I have broken during operation, and it's not a very comfortable thing when you see on table, and worse when you see after the surgery that there is a fracture which you have maybe noticed or not noticed. So these can be classified again like the other fractures, like other Duncan classification: metaphyseal A, diaphyseal B around stem, and C beyond stem. And they are subclassified as a group 1, 2, 3, either a simple perforation or undisplaced fracture or a displaced fracture. So again, these also require treatment more or less on a similar principle. Only thing is, because they have happened during the surgery, if you can notice on table, then you can treat them. And what are the indication that things has happened? The commonest thing is we very rarely get intra-op fractures in a cemented THR. 95% cases like this happen in a non-cemented THR. So what happens is, if you are broaching and putting an implant and suddenly you find that size 9 or 10 broach may be going with difficulty, and for some reason suddenly you are able to put couple of higher, like from 10 you go to 11 and 12, and they are going very easily in, while you are finding difficulty at 9 or 10, then it has to ring a bell in your mind that okay, what's the situation, why I was finding difficulty for 9 or 10 and now 11, 12 is going easily. So this is something which you have to be careful. Second thing is, if you are doing approach which is a minimally invasive approach, or if you are doing approach which is not accustomed, you are not accustomed to that, then there is a risk, like anterolateral approach has got a higher risk than a posterior approach in terms of intra-op fractures. Basically because the posterior approach, the entire femur is in front of the surgeon and they can easily see it very well. While in a case of anterolateral approach, you may not be able to see the distal part of a femur. And I've seen that in one of the cases in England when I was assisting one of the surgeon. He just entered from the front and the entire shaft perforated the posterior part, and there was a huge posterior perforation, and we noticed it only after the surgery. So perforation can happen during the surgery. It could be simple perforation or it could be a fracture, either displaced or undisplaced. Now, just a case example of a patient. A patient has got an AVN and a surgeon has put a fibular graft on both the side, which is a quite accepted standard technique of trying to treat AVN in young patient to prevent further collapse. And the collapse continues, patient gets secondary arthritis and require a hip replacement surgery. Now, as you all know, the problem is when you have got a healed internal fibular graft, which is a tricortical graft, it's a very hard bone, and we want to try to broach inside. It is not easy for the broach to go inside. That hard bone has to be sometime burr out. We have to use a burr or a sharp osteotome or a gouge to remove that bone so that you can have direct access into the proximal part of the femur. Now, the surgeon has put the implant, done all that thing, and we have put the stem, and you can see it looks very nice and very good. But then after the surgery, after second, third day, when a patient started walking, we found that patient had a lot of pain, and the patient said, "Doctor, I don't feel good. I was okay on the first and second day, but third day I found something is wrong." We took an X-ray again, and you can see that there is a calcar fracture which was seen not immediately, but on third day of surgery. Patient was still in a hospital. We can see the drain tube is still there in the second X-ray. Now, obviously, this is a case which has happened. I have to go back. We have to open the patient and we have to rewire him again. And we cannot leave it like this, hoping that it will heal on its own. Because as I had mentioned in my previous lecture, if the calcar is broken and if your implant starts sinking inside, as the implant sink inside, your vertical length of the head become less. automatically your abductors are going to become loose. And while sinking in, the implant may sink in straight or may sink in a rotation like a cork inside, like a corkscrew, and then your version also changes. And that is a potent recipe for getting a post-op dislocation. So these cases, you have to go back, open the patient, and wire it back together with multiple wires. And on table, if you find it is good, you can keep. If you find the implant is not good, you can go back and use one size bigger implant and bang it in so that it become much more solid. Now this is a coral stem, which is a HA coated, fully porous coated and fully HA coated. So it is a good thing, because if the implant get bone ingrown, and coral can get bone ingrown in a matter of 6 to 8 weeks. I have tried to remove a coral 8 weeks after the primary surgery. It was extremely difficult because bone ingrowth becomes quite rapid. So this becomes like an internal biological plate, and this calcar heals very well, and this patient in the long run had no problem. But it is very important to notice these things, and this happens. Now, question is, when do you get these fractures, intraop fractures? As I said, too hard bone or a too soft bone, either of them can give you fracture. RA patient on steroids, the bone is very soft. You try to use a non-cemented implant because you are fond of those non-cemented implant and you don't want to put cement in the medullary cavity. Well, you are more prone to get fracture during surgery. Maybe antevoted femoral neck, hip dysplasia, THR in mal-united fracture which is fixed or mal-treated. All these cases, the femoral geometry is damaged, distorted, and you can get a fracture. So certain things which has come out through the literature. Number one, it is quite common in non-cemented. 90% of them happen in non-cemented. Very rare in cemented THR. More common in LX experience, which is quite obvious, and can be missed in more than 50% cases on table. So in this case which I showed you, it was my case and I missed it. There may have been a tiny crack in a bone which was not seen. It actually was not even noticed on the table post-op immediate X-ray, but we saw that thing opening up on the third or fourth day when the patient was walking. So it must have happened during operation. It cannot happen afterwards. So you can be missed in more than 50% cases on table. Now, some articles justifying all this which I mentioned, that higher risk in a cementless CLS stem, 2.1% rate of calcal fracture. It is design related. Rectangular implant in oblong bone can cause, like CLS stem. Now we don't have those CLS stem today, but we used to get it in the past quite regularly. It's a square stem, and a square stem you put in a round bone. It can cause junction at the edge of a square and an internal part of a round bone and create a very high level of internal stresses which can cause a crack during the surgery. Now, neck cut placement and neck cut height has no effect on this increased incidence of calcar fracture. Now, let us see how it happens. Now, you have got this femur shaft, and the yellow line is the axis of the femur shaft, and depending on how the neck version is or the neck shaft angle is, the center of your shaft may not coincide with the center of the your cut. Now, if you can see here, when you take a neck cut, the pink circle is the neck cut and a yellow circle is the axis of the medullary cavity. Now, if you go little down and you have to put the implant, you can see that tendency of a surgeon is to go through the center of a neck. So you are accessing the shaft by from the center of the neck, like what you can see on the red dotted arrow. So when that happens, you eventually end up causing a problem because your broach is going in an oblique direction. Instead of that, if you take a cut which is proper cut, which is from the base of your piriformis fossa, then you can see that the yellow dot comes inside the neck, and there you can actually access the center of the femoral shaft by going through the center of the calcar. So basically, neck cut height and neck cut inclination has a big difference and significant effect on whether you will create a fracture of a calcar. So if you don't get a proper neck cut, if you don't enter the medullary cavity properly by going lateral and posterior into the neck cut, then you may end up going obliquely and create a calcar fracture. And that happens not so uncommon in an osteoporotic bone. So what treatment option you have if you get a calcar fracture? Obviously, you have to extend the fracture, try to extend the exposure, try to align and reduce that fracture, and then you may have to use a different kind of a stem, either use a long stem or you can use a cemented stem, but make sure you have got a proper stability of a femoral stem after fixing the calcar fracture. Now, if the fracture is above the lesser trochanter, then metaphyseal sleeve is intact and a basic stability is good. And a cerclage wire is just enough. It can hold the fracture, so you can use an implant, use the wire, reduce the fracture, and then gently tap the actual implant in. Try not to hammer it very hard, and that is usually good enough. But if the calcar fracture go below the lesser trochanter, then obviously your metaphyseal stability is affected. In which case, if the fracture has gone way below the lesser trochanter, you may actually require a longer implant, which has got a diaphyseal fixation, and you have to use a proper cerclage wire, and you may convert it into a cemented implant if you do not have a long implant, because not many times you keep a long stem option available on table during these surgeries. So basically, we have to be careful when you see the fracture. You have to increase your exposure. It is very important that you feel there is a fracture. Don't be hesitant to expose more. Go down all the way till you can see the lower end of the crack with your own eyes. It's very important to realize this. Otherwise, the crack may have gone much deeper or much distal than what you actually expect it to go. And then you will do a half-hearted intraop assessment, and then eventually the implant will become loose and fail. If the fracture extends down into the diaphysis, that's a bad situation. And then you may have to remove the original stem, fix the fracture with a wire. Then you can use other cemented non-cemented stem, and you may also use an external plate to fix the fracture on table during the surgery itself to give an additional stability to the bone. So just an example, what you must not do, you can see that the patient cemented THR was done and the surgeon found a spiral fracture going down, and they just did reduced it and put interfragmentary screws and left like this. Now, well, it looks reasonably reduced on the post-op X-ray over here. You can expect exactly what will happen in the subsequent X-rays. So gradually the whole area starts sinking, and eventually everything fell down and the fracture just got into problem, required a full-fledged revision there and a new big surgery. So these are the incomplete or half-hearted surgical attempts. If you are doing a surgery, make sure that what you do on table. First chance what you get is the best chance, and you may not get a second, third chance, because that means a bigger operation, and sometimes patient may not be very happy with this and may not stick to you in the future. Now, what happened to the fracture discovered after post-op X-ray? Number one is, if you find that after surgery you are taken an X-ray next day and you find a fracture there, it's a very difficult situation for a surgeon to get on your hand. And believe me, I have got a couple of cases like this where I have seen the X-ray. You saw actually one of the case. I could see the X-ray showing a fracture afterwards. What is very important is the moment you see it, you must be frank with the patient. You must tell yourself to the patient that this thing can happen, that there could be some minor crack which may not have seen during the surgery, may have got, and you must tell him that we must open, we must fix it, and this in 90-95% cases will do well. And in the long run, end of 3 months or end of 4 months, patient will be as good as he would have been without this crack. So if you are frank with the patient, explain them, talk to them, they may not like it, but they will still be okay, for the surgery, and probably you will come out of this without any major issues. Be gentle with the bones. You have to be careful. What you need is not a carpenter's roughness, but you need a gardener's gentleness in doing the surgery, especially because we treat a lot of elderly people who are osteoporotic, who are very poor quality bone. So thank you very much and good luck to you.